DMEK in eyes with pseudoexfoliation syndrome is something I've never read anything about. I've never seen any videos about it, which is actually a shame because pseudoexfoliation is not rare. We see it all the time, and these are some of the most challenging DMEK operations we do. You know, people think of difficult DMEK as being the exotic cases, the eyes with tube shunts or scleral fixated lenses or iris suturing or post-vitrectomy. Those cases are actually weirdly mostly normal. The operations are weirdly, usually just exactly the same as a normal case, but that is not the situation with an eye with pseudoexfoliation syndrome. These are challenging eyes, and this is a case that I want to show you that we did in our office just 5 days ago. This is actually a family member of an optometrist who sends us patients. This is somebody that you really want to get right. And I want to show you how we tackled this case, why this surprisingly benign looking eye is full of so many traps, and how to deal with those potential mishaps. So we start the operation the way we always do. We give a little sub-Tenon's block using 1 cc of liposomal bupivacaine, otherwise known as Exparel. And we like Exparel because it keeps the eye blocked for 3 days. And we use 1 cc because we don't want to increase the posterior pressure on any eye, let alone an eye like this. Now look at this eye. This eye looks pretty benign. It looks like an eye that is pseudophakic. It's got a decompensated DSEK on the back, but you think, okay, there's nothing that looks all that intimidating. But if you look closer, you'll start to see some problems. Problem 1, the DSEK graft is slightly decentered, so maybe the surgeon who put it on was just not quite paying attention that day, or maybe it was more challenging during that operation than you thought. Maybe there's some reason why it's not perfectly centered. But more ominous is there are iris defects. There are transillumination defects, especially temporally, but also superiorly. And you get those from complicated previous surgery. So we know that this patient has had surgery before. That was difficult, okay? So we charge into this case, but already there are indications that this is going to be a difficult operation. We're doing our basically decimetorexis under air. We're stripping the patient's previously failed DSEK graft from the back surface of the cornea. The AC maintainer we're using is 23 gauge, and it's connected to a 60 cc syringe. And my assistant is holding the syringe, and he or she is depressing the plunger, and that inflates the anterior chamber. But what you'll notice is as we go along in the case, and I'm stripping Descemet's membrane from the back surface of the cornea, the chamber doesn't seem like it's really being maintained all that well. If you look over temporally, you'll notice the bubble doesn't stretch all the way out to the temporal limbus. It's having difficulty. The bubble tends to want to shrink and consolidate into the center of the eye. Why? Isn't that weird? Well, what it suggests is that this is an eye with high posterior pressure. There is pressure from behind pushing things forward, the lens, the iris, that is overwhelming the ability of the anterior chamber maintainer to deepen the AC. Why would that be? Well, the normal cases of posterior pressure don't apply in this situation. This is not some big obese woman. This is a thin 74-year-old lady. And I mention the age because she has syneretic vitreous. And when you have syneretic vitreous, it's kind of almost like you've been vitrectomized already. If you have watery vitreous that doesn't hold its bodily shape, then you should have a deep chamber. You shouldn't have a shallow chamber. If you have a thin lady that has an eyelid speculum that's not overly stretching out the area around the eye, you don't have a good reason to have a collapsing anterior chamber. We didn't give some super high volume of sub-Tenon's block. So why is the bubble shrinking in the eye? Why is the chamber becoming more unstable? The reason the chamber is worsening as we go through this case, as I pick around the edges and try to remove these fibrotic remnants of Descemet's membrane, is because in this patient with pseudoexfoliation syndrome, we are experiencing misdirection of the air posteriorly. the anterior chamber maintainer is delivering air right now into the back of the eye. And you'll notice the IOL is coming forward. You'll see that the optic of the IOL right now is above the iris plane. And you can start to see the blue haptic plugged into the optic start to appear. So this IOL is moving. It is not stable, okay? And that's what I'm pointing out here. We actually have an observer in the OR, and I'm pointing out to her, look at the IOL right now. It's coming forward. And we see this, of course, in patients with pseudoexfoliation syndrome. We see crappy iris, and we see weak zonules, and the lens in the capsular bag are moving forward, and the chamber is shallowing despite our AC maintainer. And look, the iris, which was already thready and weak in front of my clear corneal incision, is just getting worse and worse, traumatized by me coming in and out of the wound. So it's apparent to me already at this point in the case, I've made a mistake by making the wound where I normally do temporally. I should have seen the iris being abnormal in that location and said, I need to make a wound away from the iris there. Because I know for a fact previous surgeons have operated right here in this spot and had problems with the iris. And the benign appearance of the eye deceived me. So I made a wound in a location where it was basically guaranteed you're going to have iris problems. So as I continue to manipulate the eye, coming in and out of these wounds, trying to peel off these fibrotic remnants of Descemet's membrane, the IOLs just became behaving worse and worse. It's coming up further and further. The chamber is becoming shallower and shallower, and it's more difficult to operate. Look at the position of the IOL. Not only is the optic entirely above the iris, but you can see the haptic. You can see basically the full length of the haptic because this IOL is drifted nasally and inferiorly. It is in a profoundly abnormal location. So you'll see this is going to be a major problem. This is a major problem. How in the world are we going to put a DMEK in this eye and unfold the graft with this big pupil with an IOL that wants to come up above the iris? If you can't deepen the chamber, there's no way you can unfold this graft. And look at the capsular rexus edge. You see that abnormal capsular rexus edge? This is an eye that's got major zonule problems, okay? So what do you do in this situation? Well, the first thing I'm doing is I'm hydrating all of these wounds. I'm hydrating the para, I'm hydrating the main wound, because it's important to know that these are not leaking, because I don't want that contributing to the chamber instability. And as I do that, that iris is starting to prolapse out through that temporal incision. And I immediately recognize, don't want that to happen. We do not want this iris to become utterly wasted in that location, or you're really going to have issues, okay? If you have this tattered, raggedy, nasty iris, there's no way you'll be able to unfold the DMEK graft, because not only will those iris shreds interact with the tissue, but then you won't have a plane to put the bubble on. You really need a bubble underneath the graft and on top of the iris. But if you have this wacky, wonky iris that's missing tissue, the air won't stay on top of the iris. It'll go underneath the iris, and you won't be able to lift the graft up. So it's a major problem to screw up the iris in a bad way. So what do we do about it? Well, what I'm going to do is the same thing you're taught to do when you have problems with an iris, when you're doing phaco, which is that if the wound is an issue, what you do is you abandon that wound and you create another one. So what I'm doing is I'm making an additional wound adjacent to the primary wound I was using before, where the iris is more normal. So this is a suboptimal solution. I should have made a better initial wound, but this is the best of this situation as we can make it, to make an additional wound for me to make an iridotomy so our patient doesn't get a pupillary block after the operation. So I've made an additional wound that I will use instead of this previous temporal incision. Now I've got the iridotomy made and I'm trying to deepen the chamber. It looks like this is the best we're going to get at this point. So now it's time to inject our DMEK graft. So I'm deepening the chamber here, and I've got our graft here in our Dort cannula, and I'm injecting it into the eye. And It's very important at this stage to keep in mind a couple of things. Number one, you don't want to inject the graft through the pupil, okay? If you inject the graft into the back of the eye, it's going to be a major, major problem. So you want to aim the graft such that it's in a way that it's not going to be shot through the pupil. The next thing is you want to avoid overinflating the anterior chamber, because what you put in the eye is going to tend to track into the back of the eye because of aqueous misdirection. So the more fluid you inject into the AC, paradoxically, the shallower the chamber is going to become. Because as you inject fluid, it's going to want to go posterior. The eye will become rock hard and the chamber will be shallow, and the iris is going to start prolapsing out through the wounds, and it's going to be a disaster. So what do? Well, what I like to do in these cases where you have a shallow anterior chamber and aqueous misdirection is usually putting bubbles in the eye. That doesn't help. The bubbles behave too unpredictably. They're too bad to try to control and manipulate. With a shallow chamber, it's tough to access the bubbles. I like to unfold the graft with jets of fluid if I can. And the key concept is you want to be squirting fluid through a paracentesis or through the main wound. And as you squirt, you want to be burping the wound such that you don't jack the pressure up inside of the eye or even pump fluid into the eye. You want the fluid that you inject to be cycling through the eye. You want it to go in, interact with the graft, and then flush out again. So rather than trying to deepen the chamber, what you really want to do is flush the graft to get it to turn and manipulate and spin and open within the cramped confines that you have to work with. So here I am now, I'm trying to flip the graft over because, of course, our luck is the graft is injected upside down. So I'm squirting and trying to tilt and tumble the graft, but there's just not a lot of room. See, I try to flip the graft over, but it's just smashed in between the iris surface and the IOL optic, and it tends to want to crumple into this configuration. Some people call it the crumpled or the scrambled. Some people call it the origami configuration, but it is sort of this double folded over wadded mess. And you think, oh God, well, what do I do here? Okay. Well, it's important not to panic. The concept is you want to deepen the chamber if you can, and you want to flush the graft such that it has room to move, room to manipulate. So rather than squirting directly at the tissue, you squirt adjacent to the tissue to try to get it to spin, and you tap on the pointy edges. So that's how we broke that origami configuration. And look, the graft is there, it's totally unfolded. Surgery over, right? Well, is it upside down or right side up? I can't really tell, but I'm going to use that bubble over there, which I'm pointing out to our observer. The bubble is underneath the graft, and I'm pushing the bubble into the edges of the graft, and unfortunately, the bubble is interacting with the edge of the graft, which means the curl is down and the graft is still upside down, which is so depressing that the graft is still upside down. It's totally unfolded. You would be finished, but the graft is upside down, so you have to flip it over. The way you flip it is the same way you always flip a graft, is you inject while you burp a wound to create a cycle of fluid that tumbles the graft inside of the eye, okay? So you don't squirt directly into the tissue, you squirt underneath the graft. That creates this lifting current that flips the graft over. And that's what we did there. Now the graft is totally unfolded, and it's easy to sort of iron out these little lingering edges with a little Dierzheimer taps on the surface of the eye, which is what we have here. And these are just some sort of shuffling bumps to move the graft over to a more central location. In order to facilitate movement of the graft, you can deepen the eye a little bit with some fluid, and that helps you push it over, and then we'll lift it with an air bubble underneath. So now the graft is more or less fully unfolded. It's a little bit nasally and inferiorly decentered, ironically exactly the same as the patient's previous DSEK was a little bit nasally and inferiorly decentered. So it turns out that wasn't a coincidence. It was a function of the difficulty of this eye. And now the anterior chamber is filled with air and the operation is complete. So this is a surgery that took us 30 minutes. I scrubbed through the parts there to show you basically the gist of what we were doing. And most of that operation was removing Descemet's membrane. It was preparing the eye. The graft unfolding was just 3 or 4 minutes. But normally that's a 30-second procedure, graft unfolding. This was a difficult case. This is one of the most difficult cases we did that week, if not the most difficult case. And the eye looks so very benign. But the reason that this eye was difficult is because it's got a shallow anterior chamber because of zonular instability, which is absolutely classic for eyes with pseudoexfoliation syndrome. So when you work on an eye with that condition, you have to be ready for the IOL to misbehave, and you have to be ready to approach it with the right mindset, which is to expect problems, to know that the chamber is going to be shallow, so you use a smaller graft, and you want to avoid over-injecting fluid. And then when you do inject fluid, you want to be depressing the wound so you get cycling of fluid inside of the eye rather than a buildup of pressure. These are the techniques that help us tackle these complicated DMEK and pseudoexfoliation eyes and DMEK and other eyes with shallow anterior chambers. If you can learn from our mistakes and the problems that we've had to tackle and things we've had to do the hard way, it make your own operations easier and more enjoyable.